ओम श्री गुरुभ्यो नमः. ओम श्री भवानी शंकराय नमः. ओम श्री मात्रे नमः. आयज कार्यक्रम आम्ही सभा प्रारंभ प्रार्थनेने प्रारंभ करूया. दक्षिणास्य समारंभा शंकराचार्य मध्यमा अस्मदाचार्य पर्यंता स्मर्या गुरु परंपरा श्रुति स्मृति पुराणानाम आलयं करुणालयं नमामि भगवत्पादं शंकरं लोकशंकरं शंकरं शंकराचार्यं केशवं बादरायणं सूत्रभाष्यकृतौ वन्दे भगवन्तौ पुनः पुनः. ईश्वरो गुरुरात्मेति मूर्तिभेदविभागिने व्योमव्याप्तदेहाय दक्षिणामूर्तये नमः. परिज्ञानाश्रम श्री गुरुशंकर परिज्ञानाश्रम शंकर सद्गुरु केशव वामन कृष्ण पांडुरंग आनंद परिज्ञान गुरु सद्योजात शंकर सद्गुरु. गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरु साक्षात् परब्रह्म तस्मै श्री गुरवे नमः. ओम सहना भवतु सहनौ भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै. ओम शांति शांति शांति. Jai Shankar. Welcome everyone to this first edition of the Sayujyam digital series. Before we start the proceedings for the day, I would like to invite Krishnanand Hebadekar ma'am, who is the president of Pune Sabha and also leading the Sayujyam digital series as a part of the Sayujyam team. Also, Kuti ma'am, as we lovingly call him at the Shibirs, also heads the Shibirs team at Shri Chitrapur Mat. I'd like to invite Krishnanand Hebadekar ma'am.
Thank you, Aditya. Jai Shankar, everyone. And today we are going to flag off the first of a series of lectures online or interactive webinars on various topics. We have planned a few programs online and the authorities permitting physically outdoor activities and other things like shibirs. But under the present conditions, we will start off with online programs, and later on, perhaps towards the end of the year, things opening up, hopefully, we should be able to organize some other activities also. So the first of these today is called Demystifying the Second COVID Wave, which is one of the most talked about topics today. And we have a panel of doctors, and I would like Aditya to take the program forward. Thank you. Jai Shankar.
Thank you, Krishnanand ma'am. So as ma'am said, we are starting the series of online events with this webinar on demystifying the second COVID wave, which will be moderated by Dr. Chaitanya Gulvady ma'am, and also there will be a panel of experts from our community who will share their insights on various topics. Dr. Chaitanya Gulvady ma'am, as many of you know him, graduated from the Grant Medical College, Sir JJ Group of Hospitals in Mumbai, and after a short stint of general practice in Villeparle, he worked with a lot of organizations, including Premier Automobiles, Larsen & Toubro, Reliance Industries as a medical officer. He also was the head and VP of Medical Services Siemens Limited. He retired recently from this organization. He's been also awarded several orations, including the Dr. CKR oration, Sir Adeshir Dalal oration, and the Fellowship of the Indian Association of Occupational Health. He's also presented several scientific papers at national and international conferences. With this, I'd like to invite Dr. Chaitanya Gulvady ma'am to take over the session.
Thank you, Aditya, for the kind introduction. Nidhe sarva vidyanam Vishaje bhavaroginam Gurave sarvalokanam Dakshinamurtaye namaha. Om Shri Gurubhyo Namaha, Shri Bhavani Shankaraya Namaha, Shri Matre Namaha. परम पूज्य श्रीमद सद्योजा शंकराश्रम सामंगल चरणांत साष्टांग प्रणाम करून तुमक सर्वांक सप्रेम नमस्कार आणि ह्या कोविड सेमिनाराक हार्दिक स्वागत व्यक्त करता. Demystifying the second COVID spike. Subject introduce करू का? तुमक सर्वांक गोत आसची the COVID epidemic started more than a year back, I think in late October, November, December from Wuhan in China. And then it gradually spread around the world, initially affecting some of the European countries like Italy and Germany, and then it went on to the USA. And before we knew it, it had spread all over the world. Not one country was not affected by it. Every country on all the continents was affected by it. Of course, there have been small epidemics, pandemics, like we had SARS virus in China, Taiwan, Macau, Hong Kong, and Magiri the MERS virus epidemic that was seen in Middle East, Africa. Then we saw Ebola, which was restricted to the northwest African countries like Congo, Gabon, Nigeria, Ivory Coast. But they were restricted to their particular areas. She spreading across all over the world, not leaving even one country unaffected, was like the early in 19th century into influenza epidemic munzalela. That had affected almost the whole world. That was the pandemic that some of our seniors would have probably seen. But this COVID pandemic was something really very different. And governments had to enforce lockdowns, complete national lockdowns. Overnight, our Prime Minister had to announce a lockdown, and the next day, the whole country went into a national lockdown. Similarly, Ashi lockdowns all over the world, and it threw all the national economies into total disruption. A lot of people have suffered from this disease. You see day in and out on the television. And a lot of young people, young productive people have also lost their lives. The medical infrastructure that most of our countries had has been stretched to the highest limits. The doctors, the paramedics, and the medical staff have been fighting a valiant battle, but they have been simply overburdened by the number of casualties. We owe a deep debt of gratitude to all of these doctors, nurses, and the hospital staff. To elaborate more on this disease, we have 4 esteemed speakers on the panel today. Allow me to introduce to you all of them. Can we have the first slide? The first speaker will be Dr. Madhur Amembal Rao. He completed his graduation, his MBBS from the Kasturba Medical College at Mangalore, and subsequently went on to do his post-graduation in tropical medicine from the London School of Hygiene and Tropical Medicine. He had a short stint at the Aga Khan Hospital in Kenya, and then went on to do medical practice with Bupa, which is a healthcare provider in the United Kingdom. He also did an MBA in hospital administration from the University of Gloucestershire in UK. He came back to India, and he's now the senior medical administrator at the KM Hospital in Pune, which is actually the vortex of the epidemic around Pune. He has several hobbies such as listening to Indian classical music, and he loves traveling. The next speaker is Dr. Gajanan Mankikar ma'am. I'm sure most of you know him because of his activities in our mutt. He completed his MBBS from the BJ Medical College, the prestigious BJ Medical College in Pune, and went on to do his post-graduation in Paediatrics from the BJ Medical College in Pune itself. He set up a pediatric hospital at Bhosri in Pimpri Chinchwad, and then he is also the president of the Anand Medical Foundation, which runs a school and a nursing institute at Kurli. Of course, we all know he's a very deeply spiritual person and dedicated to the Shri Chitrapur Math at Shirali. The next speaker is Dr. Sangeeta Nadkarni. Can we have the next slide? Yeah. Dr. Sangeeta Nadkarni completed her graduation from my college, I must say, the Grant Medical College of the Sir J.J. Group of Hospitals in Mumbai. And she went on to do her post-graduation in pathology from another prestigious institute, the Seth G.S. Medical College of KM Hospital, Mumbai. She worked for several hospitals such as the Sancheti Hospital, Shanti Clinic, and Krishna Hospital in Pune. She has tremendous experience behind her 33 years as a practicing pathologist. She set up the Nadkarni Path Lab in Pune and is presently also attached to the Shashwat Hospital in Kothurud, Pune. Our last speaker is Dr. Vivekanand Nadkarni. He completed his graduation, his MBBS, and then went on to do a diploma in tropical medicine from London. He was, for a certain period of time, the medical officer in charge of interior medical services at petroleum development in Oman. He had also worked as a medical officer with the Halliburton Geophysical at their locations in Africa. He also has had done residency training in Mumbai. Presently, he is a practicing physician in tropical and family medicine in Kothurud in Pune. So to come to the questions, can we have all the speakers on the screen so that I can pose the questions to the speakers? So the first question is being addressed to Dr. Madhur Amembal. Dr. Amembal, given your experience, I must say, in the epicenter of the pandemic in Pune, in fact, if I remember, the numbers in Pune at some point of time were much higher than the numbers in Mumbai. Could you briefly elucidate on the causes of this pandemic and the spikes that we are going through? Of course, we did see, after the first episode, we did see the second spike or the third spike in countries like UK, Germany, and Italy, and Spain, and of course in the USA. But there was a lull in the pandemic, especially in India. The numbers kept going down, and we kind of relaxed. And suddenly we were attacked by the second spike in early April, in mid-April, I must say. What could have caused this spike? Can you elaborate a little more on this COVID pandemic and the spikes that we are seeing? Over to you, Doctor.
Jay, thank you, Jay Shankar, and thank you, Chaitanya ma'am. I'll just pick up on where you left in terms of the lockdown that was first imposed in March, and just run through a timeline of what has happened in India during this pandemic. As we are all aware, it was for 3 weeks. There are two schools of thought about the impact of lockdowns. I won't go into the details of it, other than to say that a recent paper in the Lancet just this week talks about how countries that have adopted the elimination strategy have successfully controlled their numbers, and those are the countries like South Korea, Iceland, New Zealand, because they locked down, in the sense, all their borders, but they had an aggressive testing, tracing, and isolation, which helped them to control their numbers, which unfortunately we lacked and we didn't do even during the first wave. We were not testing enough people, tracing or isolating them. Our numbers, as you rightly said, started growing towards August, and September was the peak in which our numbers were overflowing in all our hospitals. We saw those pictures of people waiting in long queues to get into the hospitals. And September, October was a very bad period for us here, particularly at the hospital, and for all the hospitals in and around Pune and rest of Maharashtra. One thing that we did notice during that first wave was the admissions that we were getting were the ones where there were people who were of the older age group. They were, in the sense, not families necessarily being affected. And there were also no children that were coming in. And it was almost being assumed at one stage that children are immune from the COVID disease. I'm trying to make this distinction from what we are now seeing, because there's a vast difference in what we are now beginning to see. And what happened, as you said, almost miraculously, the numbers started dropping. All our COVID beds started freeing up, and we were having non-COVID admissions that were filling in and taking up the place of where our COVID patients were. So I think one of the reasons and main reasons was one, complacency set in. We all let our guard down. We had even officials from the government who were literally bragging about how well we had controlled this particular wave, and we were a shining example for the rest of the world. And you started noticing that there were events like weddings, there were religious functions that were being held, and obviously the Election Commission decided for whatever reason to hold elections in those states. These were super spreader events, as we would refer to them. And we then started noticing the numbers suddenly going up. And where the difference was that we were now seeing entire families being brought in. We were also seeing that the age group was differing now. We were seeing the 15 to 49 age group, which was being affected. And sadly, we have right now, and I speak from the hospital boardroom, where we have very young people who are on ventilators at the moment. And we also have children who have been affected, and babies as young as 4 months. And I'm sure Gajanan ma'am will talk about this effect on children who are now being admitted to the hospital. So complacency was one thing. We started the vaccination program in January. There was at that stage what we refer to as vaccine hesitancy. We had already gone through what is often referred to as COVID fatigue. Everybody was tired, everybody wanted to have a break, and most people felt that there was no need to even vaccinate. We had, unfortunately, even some of our doctors saying, why should I vaccinate when the numbers are already low and down? So complacency was one, vaccine hesitancy was the second, because other countries that have successfully vaccinated, you take examples of Israel or even the United Kingdom that has vaccinated over 50% of their population, have made a better go at least getting their population controlled in that sense. And the third thing that I know that Sangeeta Pachi will talk about is the mutant strain. I don't want to go into that because I think that's the important one, because the clinical picture that we are seeing now is very different from what we were seeing earlier. So the B1617, which I know she will talk about, is probably responsible because it's more infective, more transmissible, and that has probably caused a big spike in the number that we are seeing at the moment in Pune and in the rest of the country.
Thank you, Mom. Thank you for your description of the COVID epidemic. I go over to Dr. Nadkarni Sangeeta Pachi. Dr. Sangeeta, you are a senior pathologist. Can you tell us about the nature of this COVID virus? How is the virus transmitted? And what exactly is this viral mutation? How does a mutant virus differ from the original COVID virus? We have heard of the UK variant, the South African variant, the Brazilian variant, and now we hear of an Indian variant. They call it a double mutant. Why is this so-called Indian mutant so very infectious, unlike the original COVID virus? Also, I would like you to talk about later, after you're done with this, I would like to ask you, what are the diagnostic tests for the COVID virus? For example, we've heard the most important test, of course, we all know is the RT-PCR. But we also at one point of time heard of the RAT test, the rapid antibody test. And then we also heard of the CB-NAT and TrueNAT. Can you elaborate a little about these different types of diagnosis and what is the difference between them? And also, as a doctor myself, I also treat a lot of patients. So I have seen that the reports carry something called as a CT score. And I've had queries coming in from patients asking me what is my CT score is low and my CT score is high. Is it going to make a difference? Am I going to be worse? And am I going to be progressing towards hospitalization or something of that sort? And what are the other pathology tests or the radiological tests that a patient should undergo during the course of the disease? And should we do it as frequently? Because in some cases, I have observed that these patients on their own keep doing these blood tests like the C-reactive protein, the ferritin tests, or you have the various other tests, the platelet counts, the CBC, their blood sugars, and all these tests are done repeatedly during the course of the disease. Is there a need to do a repetition is what I would like to know. And I would also want you to tell us, after the course of the disease is over, there are people who at the end of 10 days or 12 days do a RT-PCR again just to check whether they are positive or negative. Is that very important? Because at one point of time, the central government and the institute sent direction that there was no need to do a test again after you recover from the disease. Over to you, Dr. Sangeeta.
Thank you, Dr. Chaitanya and Jai Shankar. Now, what is the nature of this COVID virus? This COVID virus is the beta coronavirus. It's the same virus as you have mentioned, the SARS-CoV-2, which we had outbreaks in the Middle East last time. And it is you have viruses which are DNA and RNA, and our COVID-19 virus is an RNA virus. So it is a very simple virus in the sense it has an envelope with nuclear capsid and spike proteins. And this is a simple thing. And what is meant by DNA and RNA? DNA means double-stranded DNA and deoxyribonucleic acid. RNA is ribonucleic acid. So viruses are RNA and DNA. COVID-19 is an RNA virus. Now, how is this virus transmitted? They have found that because in Wuhan, when this virus originally came, it was actually in bats. It was a zoonotic disease. But later on, it emerged in human beings. And the human-to-human transmission was pretty fast. And they found that people traveling across Wuhan or going across China, and it spread like wildfire. So there was some mode of transmission which has caused this virus to spread very fast. When a COVID positive patient coughs, sneezes, or talks, a normal person standing there in front of him can get infected. But Lancet studies recently have said that because of this virus outbreak now, the double mutant one, which has given a very striking transmissibility, they say that it could be, the Lancet says that it could be airborne. That is, when the patient, the positive patient coughs, the virus could be remaining in the air and many more people could be infected. What they have found in this double mutant virus is that there is rapid transmission and the infectivity of the virus is also more. Because in the previous wave, the one COVID patient used to infect 3 to 4 out of 10 patients. But now in this wave, they have found that one COVID patient is infecting 9 out of 10 patients, 9 out of 10 people. And hence, in any functions or in any families, there are whole families getting affected, whole communities getting affected. And that's how it is rapidly spreading. And what is exactly a viral mutation? Viruses tend to replicate and multiply. And when this happens, there is a copying error of the gene. So there is an exchange in the genetic material between the viruses. And the new virus or the novel virus formed usually has a different antigenic or antibody structure. And it behaves very much differently from the original COVID virus. Like here we know, considering this wave and the previous wave, this wave, the virus is very fast transmitting. It is existing in different localities, different climates, and that is what. So basically for the virus to survive, it changes its structure, it changes its mode to the environment. Now we have these different variants which you may be hearing in the news about these different variants, the UK variant and Brazilian variant and South Africa. They say in Maharashtra, the B1167, which is a variant of a double mutant, which has 2 mutants, that is E484Q and L425R, together have formed this B1617 variant, which is pretty infectious. And this, they say, could be the UK variant. It could be in Maharashtra and Delhi and Punjab. The other one is a South African variant, which is B1135, which they say could be in Karnataka and Bangalore. And the Brazilian variant is the P1. Now we come to the diagnostics tests. Pathology is the backbone of medicine and surgery, and hence we have to give the clinician a clue that this patient is COVID positive. The most commonly used test, which all of you must have heard of, is the RT-PCR. It stands for reverse transcriptase polymerase chain reaction. Now, our COVID-19 virus is RNA, but the PCR machine detects the DNA molecules in the virus. Hence, there has to be a reverse transcriptase application from the RNA to the DNA so that the DNA of the virus is detected in the PCR machine. The samples which are taken are usually the nasal and the nasopharyngeal or the oropharyngeal. The technician is trained enough. There's a transport medium. It is taken to the lab and put in the PCR machine. They have a primer which does this amplification from RNA to DNA. And then there's a fluorescent probe which detects the DNA molecules. Now, real-time PCR is the quantification of the amplification of this DNA. That is, how many copies of the DNA are formed. Now, Chaitanya, ma'am was asking about the cycle threshold value. The report of the RT-PCR comes as a cycle threshold value. Above 35 is negative. That is, the patient is COVID negative. If it is below 35, it is positive. Now, the number depends on how many cycles the virus has taken to form the copies. That is, if it has taken only 3 or 4 or say 10, that means in a very short number of cycles, the DNA has been detected. But suppose it takes 30 cycles, that means the viral load is much lesser in the patient. But this does not really correlate with the clinical symptoms many times, because the actual course of the virus is that when the patient is positive and when the RT-PCR comes positive, sometimes the CT score is high. And this test is usually done between the 1st and the 5th day of the symptoms. Now, when the patient comes to the 6th or 7th day, between the 7th and 9th day is the crucial time when the disease may progress, the patient may deteriorate. At these times, sometimes the CT score may fall. And if the patient then afterwards usually comes back to normal, the CT score may rise or it may remain for some time. So another question Dr. Chaitanya asked was, is the RT-PCR needed to be done after 14 days? No, it's not really needed to be done unless if the patient wants to he wants to return back to duty and the office is asked, or if he wants to travel, then only it is necessary. Otherwise, it is not necessary. And what is this RAT? RAT is rapid antigen test. Now, the difference between the two is rapid antigen, as you call it, it has we have a antibody detected probe which detects the antigen of the virus. This is a very fast test, 15 to 30 minutes, and you can do one test at a time. But it's not as accurate and specific as the RT-PCR. It can give false negative results in the early stage of the disease, because this test usually comes positive when the virus is, the viremia is more and the patient is really infectious. So hence, RAT is nowadays usually used in pre-op patients or in obstetric cases, or if like a patient comes with acute pancreatitis or acute appendicitis and they want to know whether he's COVID positive. So they usually do a RAT and a CT scan and rule out COVID. So that's how it is used. And the RT-PCR is more specific. It takes about 6 to 8 hours. 92 tests can be done. The prices for both, the government first had capped it at 1,200. The RT-PCR was at 1,200 and RAT was at 250. But now the government has capped the price of RT-PCR at 650 and RAT at 150. Now, what is CB-NAT? CB-NAT and TrueNAT are both based on RT-PCR only. CB-NAT and TrueNAT were used in the National Tuberculosis Program. Now, this PCR machine has been used widely before, mainly for tuberculosis detection. The CB-NAT is usually, it takes about 45 minutes, and it's a nucleic acid amplification test cartridge based, and it is much more expensive, about around 3,000 rupees. It takes 45 minutes, one test at a time, and usually done in an emergency. If the patient comes, and more sophisticated tests done in an emergency when the patient comes, like with a heart attack or something like that, or maybe where he has to be taken immediately, he has to be operated immediately. So they need a report immediately. That's all. So the principle is the same as RT-PCR. Now, TrueNat was also in the National Tuberculosis Program. This is also a nucleic acid amplification test, but it's a chip-based battery-operated device. It is easily, it can be carried to different places. Hence, it has been used in the containment zones, also for mobile detection areas, and the staff needn't be that trained as they have to be for the RT-PCR. The last of the test now, which is a very sophisticated and most expensive test, which is still not, I think a few labs in Delhi like Lal Path and Dang may have started it. It is the Abbott ID now, which is much more expensive. A positive result comes within 5 minutes, and a negative result takes 13 minutes. And it's a isothermal gene amplification test. It is very, very specific, but it is expensive and it cannot be done on all patients.
Dr. Sangeeta, could you briefly run us through the other tests?
Yeah, now the other test, which a clinician usually, once we tell the clinician that the patient is COVID positive, usually around the 5th or 6th day, there's a small list of tests which we do. That is a complete blood count or a hemogram. Here we usually look at the total, the white blood cell count and the platelet count. In the previous wave, we found that the white blood cell counts were very high and there was a neutrophilic predominance. And the neutrophil lymphocyte ratio was more than 3.5 in all COVID positive patients. But in this way, we are seeing a dengue-like picture where the white blood cell count and platelet counts have fallen. The next test is the CRP or the C-reactive protein, which is an acute phase reactant. And this is usually raised in acute infections and inflammations. And this is usually raised in COVID positive patients. It may remain high for some time. But if it really goes very high and the patient is deteriorating, then there could be, the clinicians do suspect a superadded bacterial infection. The other basic test is, of course, a sugar random, because if a patient is a diabetic, he has to be monitored during the COVID disease, during the treatment, during the home quarantine. He has to be monitored, the sugar, especially if the patient has to be given steroids. Then we have SGPT or liver enzyme, which rises in about 40 to 50% of patients if the liver is damaged. Serum creatinine levels indicate the kidney function, and that is usually normal unless the patient has deteriorated, gone into acute renal failure, multi-organ failure, or he's already an old case of hypertension, diabetes, long-standing. The other important test is the D-dimer, which is a fibrin degradation product. And as we know that COVID-19 is inflammatory thromboembolic disease. Hence, D-dimer levels are very, very important. They usually rise in home quarantine patients also, and of course in clinically ill patient also, they are very much high. When the tests are repeated, say again on the, if necessary, is the hemogram, CRP and D-dimer. Because these are the tests which usually remain high even after about the 12 to 13 days. If the D-dimer levels still remain high in home quarantine patients, the clinician usually gives an anticoagulant for a month to prevent any thromboembolic disorder. The next is the interleukin-6, which is usually not done in home quarantine patient, but in admitted hospital setup. The reason being that once the blood is collected for interleukin-C, it has to be transported immediately to the lab, because any interference with RBCs can cause a false high interleukin-6 level. Interleukin-6 is released. It's a cytokine which is released when the virus enters the body into the vascular endothelial cells and the macrophages, and this causes a cytokine storm. And this cytokine storm worsens the patient's condition.
Thank you.
The last test is the serum ferritin levels, usually which show the iron body stores, but they have found that it is high in chronic inflammations. As Dr. Chaitanya was asking me, there are patients who do come and get their CRP and ferritin done, because suppose in one family, like 2 are positive, so they know what tests have been done with those people. So they just come later on to check, if the CRP is high, the ferritin is high, so they can get an indication whether they are, going towards COVID or what.
Correct.
So that's how we just want
little misuse of the pathological test.
Yeah.
Thank you, Dr. Sangeeta. Let's move on. The next question is to Dr. Vivek Nadkarni. Dr. Vivek, you have been in clinical practice for a very long period of time, and I'm sure you have, in the last few weeks, you would have seen a lot of COVID patients. Could you take us through the symptoms of the COVID patient that are seen? How does it progress? How does the patient monitor himself during the course of the disease? Is it necessary for a COVID patient to have a non-contact thermometer and a pulse oximeter? Because we frequently talk of pulse oximeters, the need for pulse oximeters in this disease. I would also like you to ask you whether the elderly people whether they are more prone to the COVID infections, and is it true that they could also suffer more from the complications of COVID? And so is the case with people with comorbidities. For example, some people have diabetes, high blood pressure, or some of them have undergone angioplasties or bypass surgeries, or they would have some other problems like cancer under treatment or kidney diseases. Would they be more prone to the COVID infection and the complications? Over to you, Dr. Vivek. I mean, you can start.
Jai Shankar. Thanks, Chaitanya ma'am. Pranams, everybody. The WHO has described 14 symptoms necessary for the diagnosis of COVID, and this was done sometime in April 2020, and those symptoms still hold. I'll just run you through those symptoms: headache, sore throat, cough, fever, body ache, diarrhea, vomiting, abdominal pain, loss of smell and taste, breathlessness, sense of fullness in the chest, conjunctivitis, and disorientation. I have given the symptoms in the order of frequency. The most common symptom is a headache, a sore throat, a cough, and a fever. The most specific symptom is a loss of smell. In fact, a loss of smell with a couple of other symptoms is equivalent to a CT scan diagnosis of COVID and is equivalent to a RT-PCR diagnosis of COVID. So if somebody says that, after a couple of days of fever, I've lost my smell, a doctor can justifiably tell him that it is, COVID, you better test yourself and keep away, keep yourself isolated and quarantined. The most significant symptoms are a high ongoing fever, a worsening cough, and a breathlessness. All these generally occur after the 6th or the 7th day of illness. How does it progress? I always tell my patients that this is a 12-day journey with, the doctor as the navigator who navigates you. Doni sagali munde hogali, doni irbaison bar divas kadkar. So similarly, one can say the 12 days you can divide in the first phase, that is the viremic phase, where the virus replicates itself in the body. Generally, this lasts for 7 days. And during that time, you have a slight cough, a fever. In a lot of patients, these symptoms subside in a couple of days. Day 5 and day 6 is quite significant. If the fever after subsiding starts coming again, and if it reaches above 100, 101 continuously, one should be a little alert about future consequences. How does a patient monitor himself? The second phase is the inflammatory phase, which generally starts after day 7. After day 7, the viremic phase generally fades out in most patients. The inflammatory phase is responsible, just as Dr. Sangeeta said, the cytokines that are released in patients, the body's response to the virus and the neutrophilic response to the virus, they release certain cytokines in the bodies which are responsible for the inflammatory symptoms that Dr. Sangeeta talked about. After 12 days, generally the virus, the clinical phase wears off, patients get better. And, a few people unfortunately develop complications. How does a patient monitor himself during the course of the disease? Well, as soon as he becomes, he is known to be RT-PCR positive, he needs to isolate himself and quarantine himself. The present guidelines for quarantine, home quarantine, are 16 days from the day of positivity, inclusive of the last 16 days. Huh? Now, there is a difference. It's always better for the patient to keep a diary with the day of symptoms-wise, and the day of the test. The test day is important for the quarantine. The day of symptoms is very important for to decide when the blood test or the other investigations can be done. A pulse oximeter is very useful for this purpose, especially in the elderly or most patients. A pulse oximeter is basically a spectroscopic analysis of the oxygen saturation and generally of the capillary oxygen saturation, and is a good indicator of the arterial oxygen saturation, the error being less than 2%. Generally, this is done on the middle finger. You can use the other fingers, but the middle, people advise that you use it on the middle finger. Oxygen saturation drop less than 94% is indicative that the person is desaturating. We generally tell the patient to do the pulse oximeter reading after a 6-minute walk in the room. He generally takes a 6-minute leisurely walk in the room, then sits down and takes the pulse oximeter reading. It has to be generally more than 94%. If it comes less than 94%, he needs to alert his doctor or the physicians. If this happens, generally this happens after day 76. The pulse oximeter, one more advantage of the pulse oximeter reading is that it also gives a pulse reading there. So the pulse reading, if there is tachycardia, one comes to know about it. A patient needs to monitor his pulse oximeter reading oxygen saturation, his temperature, and his pulse at least 3 times a day, and inform the doctor. Once a day, he's the caregiver, once a day or the next day. Make sure that the oxygen saturation doesn't drop below 94%. What is the next question? Are the elderly prone to COVID infection? Yes. In the second wave, we have seen people with less than 60 years, as Dr. Amembal talked about, being affected and becoming more serious. This was not very evident in the first wave. However, all the elderly patients with hypertension, diabetes, patients with previous heart surgery like CABG or an angioplasty, they need to take care and be careful and monitor themselves. Especially diabetes and hypertension, 2 things. Diabetes can worsen during a COVID infection and needs to be monitored. The fasting sugar and the post-meal sugar need to be monitored during the infection. This can be easily done with the glucometers available. Hypertension, the ACE2 receptors, which are active in hypertension, and the COVID virus also latches onto the ACE2 receptor. So that is why it's quite important. We do find that the blood pressure fluctuates, and in some cases the blood pressure may fall. So one needs to have an automatic BP apparatus handy at home The BP needs to be taken with the patient sitting up. The pulse of, mind you, all the pulse oximeter readings are to be taken with the patient sitting up. People with respiratory problems also have, need to be a little more alert because they can fall into complications. I think.
I guess that's the reason why the government decided to vaccinate the elderly patients, elderly population, and those above 45 with comorbidities. To take it further, I mean, once a patient is diagnosed, you spoke about quarantine at home. How do you, I mean, they also call it self-isolation. How do you prevent the infection from getting transmitted to other people at home? I mean, I would like you to elaborate about the masks and about the sanitizers that one needs to use. And also, I would like to ask you to elaborate on the standard domiciliary treatment that you normally give when for patients in who are at home, who are undergoing domiciliary treatment. For example, you would ask them to give steam inhalation, gargling, and sometimes you would also give them probably antibiotics and ivermectin and maybe even the present drug which is called favipiravir or Fabiflu. Are they really effective? Do they reduce the viral loads? Do they make an impact on the progress of the disease? And when would you advise a chest X-ray or maybe even a CT scan? Because a CT scan is also almost considered like an RT-PCR. Even if an RT-PCR is negative and you have a CT scan that shows a picture, then it is taken as positive. So can you elaborate a little bit on the isolation at home and on these aspects?
Yeah, once the patient is diagnosed RT-PCR, we generally ask the patient who are the elderly people at home first, and they need to be kept away from the patient because they are at, if they get the infection, it could be more severe. We also find out who are the other family members and advise them to take the tests, all the family members. When the patient isolates, preferably with a washroom, attached washroom, so that he can use one washroom, the other members of the family can use other washroom, where these facilities are available. One thing about using the washrooms is, when you use the commode, we tell the patient, please close the lid of the commode and flush the toilet, because that itself, flushing the toilets with the lid open, creates an aerosol which may go around in the house. Every time after he uses, a small disinfectant can be thrown in the washroom. Hand washing, masks. People need to wear masks at home. Frequent hand washings are always necessary and preventive distance, and social distancing at home. His food needs to be delivered at home, in his room, actually. Can you hear me now?
Yeah, we can hear you. Go ahead.
Yeah. His food needs to be delivered at home without the non-infected person entering the room. One other thing is, if he lives in an apartment, the secretary of the society or the chairman of the society needs to be informed so that the building can take proper precautions. The bio-waste that is generated at home needs to be kept separately. The municipal authorities in Pune at least come twice during this period, generally on day 4 or day 5, to collect the bio-waste and the dry waste separately. The dry waste and the bio-waste should not be mixed with the building wastes. This, every day, like the collection takes place, it needs to be kept at home separately and given to the municipal authorities, who come at least twice and make sure that it is disposed of properly. What role do vitamin supplements, the kind of mask that you can use? Well, we have this is what we call layered mask, as what generally is referred to as surgical masks. One can use that. A double mask, a lot of people use the cloth masks, and And then there is the N95 mask. Throughout the epidemic, it was initially thought that the N95 masks need to be disposed of immediately. What we have been doing is using the masks at least. So you get 5 masks, use 1 mask every 5th day, and then rotate the thing. We have been using it for the last year, and it seems to have worked. If you are using a surgical mask, you need to, it is a one-time use, and you need to dispose it off after 8 to 10 hours. You can't use it repeatedly. The cloth masks can be washed in disinfectant water, washed with soap. The virus dies off generally with soap. You can wash it, keep it out to dry, and you can use it. A double masking is very much necessary if there is a COVID patient and you are on alert, and if you are going out, it definitely helps. What role do other vitamin supplements, zinc, and all play? They're all basically antioxidant.
Ivermectin and antibiotics. Yeah. Ivermectin, antibiotics, and also the favipiravir.
Yeah. The present guide, you see, this is an evolving, and the guidelines for this has changed quite frequently. ICMR itself has come out with its 3rd or 4th guideline about 3 or 4 days back. Initially, when the epidemic started, all of us thought we were using azithromycin, antibiotics, ivermectin. We were using doxycycline. The present guidelines, ICMR guidelines, have divided the cases into 3 parts. 3 sections. Group A, which is mild, they generally do not need. If the fever subsides in 2 to 3 days time, 4 days time, which most of the time it happens, they just need paracetamol and these vitamins and monitoring. If the fever continues after 4 days, then is the question what one does. The ICMR guideline says that one can use ivermectin. Some of the states have their own guidelines. Some of the states advocate using doxycycline. Azithromycin and doxycycline were initially known to have some immunomodulatory and antiviral properties, but larger studies have said that probably this is not true. So unless it is necessary and there is secondary infection, try not to use antibiotics. In the clinical setting and with the alarms that go around, unfortunately, a lot of us tend to use antibiotics, and the symptoms anyway seem to subside. Favipiravir, the antiviral favipiravir, was subject of research. It came from Japan. It is used licensed for use in about 17 to 18 countries. It is not licensed for use in the US and the UK. In India, it has got an experimental approval. One has to sign a consent form when a person uses it. The ICMR does not find it very useful. However, you can use it since we have nothing else in home, except remdesivir, which is given in a hospitalized thing. We don't have anything else. Said the dose is quite high. It is 1,800 milligrams twice a day, day 1, and then 800 milligrams for a period of anywhere from 7 to 10 days. The per kg dose is 5 milligrams. So the doctor decides it. If the doctor takes a call to use it, please be aware that the serum uric acid needs to be monitored, and the liver functions, SGPT, and the serum creatinine needs to be monitored, especially in people with diabetes and hypertension, because they sometimes get elevated and one has to take precaution, especially the serum uric acid. However, they have not found it very useful. It doesn't seem to change the outcome of infection after day 7. The cytokine storm, if it has to happen, generally happens. This is what we have generally seen. But we are still using it. All of us are using it. Ivermectin is an anti-helminthic drug, basically used to be used in Africa for schistosomiasis and other worms. It was found to have antiviral properties but the antiviral properties require huge doses. It doesn't come at 12 milligrams. However, since again we have nothing else, some of the states and the ICMR guideline also mentions that it could be used. It is used in a dose of 12 milligrams for 3 days or 5 days. A Bangladesh study which was quoted in the Lancet says that it is useful. So that is one of the reasons they are using it. Zinc, vitamin C, and vitamin D, they play a part in boosting your immunity. They are all antioxidants. They boost your immunity. A minimum of 50 different preparations of vitamins have different quantities of zinc, and we have been taking zinc all over right from 2020. Remember, zinc is a metal and a mineral. So, we still do not know what its other effects would be. But all of us are taking it at some time.
Thank you, Dr. Vivek. I mean, could you, for want of time, we'll have to restrict our answers to the minimum. I mean, a brief note on use of chest X-rays and CT scans.
The chest X-ray and CT scan. The CT scan is basically can be used in 2 ways. On day 6 or day 7, when the patient has a high fever, worsening cough, to find out. It is not to be used early to see the progress of the disease because it just gives the same this one. If it is to be used, it is used later in the inflammatory phase or to see the progress of the disease. It can also be used for emergency cases. Whenever a patient, as Dr. Sangeeta pointed out, for emergency admissions, they do a RAT test and a CT scan to find out if he's COVID clear so that they can go ahead and do whatever emergency operative procedures that need to be.
Thank you, Dr. Vivek. That was a very elaborate answer. Coming to you, Dr. Madhur Amembal, you've been in the center of the storm. In your experience in KM Hospital, how would you, describe? Because when the second spike came in, we had a sudden rush of all COVID patients to hospitals. Every patient who was diagnosed with positive rushed to the hospital to get himself admitted, and the hospitals were full of patients with no beds at all for even the serious patients requiring admissions. Is it necessary for all COVID patients to get admitted on the diagnosis of COVID? What do you feel? When is it necessary to hospitalize a patient into the hospital? And what is the role of oxygen supplementation in the patient? Also later, I would like you to elaborate on drugs like remdesivir, steroids, tocilizumab. What role do they play in the treatment of COVID? And, there is, we often hear about, the very high demand for remdesivir. I had heard that it was an experimental drug. And, there is a severe shortage and scarcity of remdesivir. And people are running around. There is a huge black market in remdesivir. What role does remdesivir play? Is it really necessary? And earlier, we did notice that COVID plasma also had a role. Do you think it plays a role? Have you seen it being used in your hospital? And I would also like you to talk a little about the complications of the disease. That is, Sangeeta and Vivek did speak about the cytokine storm, what exactly happens. And when does it become necessary to transfer a patient from just oxygen inhalation to a ventilator?
Thank you, Chaitanya. Again, we are following the AIMS ICMR guidelines that were just talked about by Dr. Vivekanand. And this is in terms of when he mentioned the mild cases, those are the ones that should be managed at home. And you're right that in our first wave, we were forced to admit everybody who was COVID positive, even if they had mild symptoms. We had to keep them for 14 days, had to do the RT-PCR on the 14th day, and if it was negative, then send them home. But if it was still positive, continue to keep them for another 7 days. This was blocking up all our beds for the really serious patients that we were getting during that. Fortunately, when the new guidelines came out in terms of home isolation, which have already been talked about and what needs to be done, that has freed up a lot of those beds. So now what we're seeing in terms of the patients who are coming, are the ones whose saturation is less than, say, 92 and below. I mean, I talk about people with 60 or 50 saturation who are also being rushed here. We are therefore getting late presentations. That's one of the things that is happening. I have mentioned also we're getting young patients who are being admitted. And what this is meaning that we have to rush them to a critical care unit. And there is a scarcity of beds in the critical care units throughout Pune. And I'm sure the case is the same in Mumbai as well. Here, the situation is slightly different in terms of the fact that 80% of our beds are in private hospitals. Therefore, the strain has come on the onus has been on the private hospitals to accommodate as many patients as possible, and we are trying our best to do that. So, in answer to your question, the ones whose saturations are dropping, initially we have to admit them either to a unit or a ward where we can give them oxygen, and then according to the guidelines that have been laid out, start them on treatment. So we've already talked about the tests that are being done, and those are the basic markers that we'll look at. We will then start on steroids, and you mentioned that. So methylprednisolone is one of the drugs that is being used and has been tried and has been successfully found to help in COVID cases. So we start them on 0.5 to 1 milligram per kg body weight, and then when they are better, we can switch them over to the oral medication of dexamethasone. The other thing, obviously, as you said, is when do we switch them over to ventilators? When they're either not maintaining or they're getting more hypoxic, the saturation is dropping, the arterial blood gases are showing that there's CO2 retention, then you will end up finding that they will need some kind of ventilatory support. So it could be either in the form of non-invasive ventilation, which is what we tend to start off with and give that a trial, which is just a mask or a helmet, and then that's how we give the oxygen. And the other is also the use of high-flow nasal oxygenation, which is commonly used at the moment. One of the problems of the high-flow nasal oxygenation machines is that they consume almost 60 to 80 liters of oxygen. And you mentioned about shortages of remdesivir, but I'm sure everybody's also read about the fact that there's an acute shortage of oxygen as well. So we are under the current guidelines, which are national guidelines, but we also have the state guidelines that have been given to us. And those are suggesting that we should limit the use of high-flow nasal oxygen machines only because of the high consumption of oxygen that these machines use. So the option would be, what I mentioned, is the non-invasive ventilation. And if that is still not controlling, and in terms of the patient is finding that his respiratory rate is more than 30, and all the other parameters are showing that there is what we call hypercapnia, which is CO2 retention, then we would unfortunately be forced to put them on a ventilator, which means that we have to put an endotracheal tube down and put them on a machine that will help them to breathe for a period of time. Again, for the severe cases, we are using methylprednisolone as a base. We are also using under both those, and something that has been mentioned about the phenomena of thromboembolic phenomena that is going on in COVID cases. Therefore, either using the unfractionated heparins, or we're also using low molecular weight heparins for that. So that's standard treatment that is given. In terms of the three drugs that you've mentioned, so the three and one is plasma. So remdesivir, yes, is used. It is definitely effective, but these three have been used in India at least under EUA, which is Emergency Use Authorization only, which means they have to be used with caution. So remdesivir is given because it does delay the replication of the virus by at least 2 days. It has to be given very early in the phase. So between 2 to 9 days is what the recommendation is by the state guidelines that we have received. And it has to be given for patients who are on oxygen. When you mentioned about the shortage of remdesivir, what happened is that the FDA have come down with a rule that we have to fill out an Annexure B form, which gives the clinical picture. Because what was happening unfortunately, that remdesivir was being indiscriminately prescribed to patients. That could have accounted for part of the shortage. Part of the shortage, as you probably read in the newspapers, what was as a result of black marketing. So they have now insisted that this Annexure B form has to be filled out, giving the clinical picture in terms of the saturation. So effectively what they're saying is that unless a patient is on oxygen, you cannot give remdesivir to that patient. It has to be in the acute phase in terms of 2 to 9 days, and we have to give a positive RT-PCR report. Now that has limitations because there are a lot of patients who will need remdesivir only because we don't want them to go into the cytokine storm that we have discussed earlier. So they may find that they are not on oxygen, but to prevent them from even getting to that stage, we would like to give it to them. And the clinicians find it's quite frustrating that in those cases now, under the present guidelines, we are not able to give it to them. The other problem is where typically a person has an HRCT score which is high, and they've got typical changes in the HRCT with ground glass appearance. They are finding that these patients also would look typically like COVID, but their RT-PCR may be negative, which means in those cases as well, these patients would not qualify to be given remdesivir, and that has become a problem because I can understand the reason why this form was instituted, but from our clinicians' point of view, they feel if it looks like COVID, all the features are there, then it has to be treated like COVID, despite the fact that RT-PCR may be negative in some of those cases. Tocilizumab is obviously a drug that has been used for rheumatoid arthritis and juvenile arthritis. That is given, and they found it to be effective in these cases as well, but it has to be given very, very early in the phase, especially based on the CRP, which we have talked about, and IL-6 values. So if you're finding that those values are very high, that's the time that it should be given. It's given as a single dose, while remdesivir is given as a loading dose as 200 milligram and then 100 milligram every day for 4 days. So that's a total of 600. So this both have a role to play. There is a recovery trial that has looked at all these drugs in the UK, and they have actually used a lot of this data that they have. They've looked at tocilizumab and they've looked at plasma as well, and they have found there's a definite use for this drug to be used in the early phases, and it has to be used with caution because this invariably are patients who are severely sick, probably on mechanical ventilation, who are going to require the drug. Regarding the plasma, convalescent plasma has been used for many years. I think some literature says that it dates back almost to 1900. It has been used because effectively what you're doing is you're removing the antibodies that are there against, in this case, COVID, and you're giving it back to a patient and allowing them to at least have that impact of the antibodies, which they may not have initially developed straight away. Again, this was part of the recovery trial, and in January of this year, the trial stopped taking any more candidates because they felt that plasma therapy necessarily was not helping. So I think the jury is still out on the question of whether plasma therapy is going to help. There are lots of trials going on, but what happens is that plasma therapy is given along with some of the other drugs. So it becomes a little difficult to differentiate whether it's the plasma therapy by itself that is helping, or it's probably a combination of the steroids and remdesivir or tocilizumab that is helping in that case. But our clinicians are quite convinced that it has a role to play. The side effects are minimal, and if it's going to help the patient in the long run, then possibly I think we should continue to give it until somebody says otherwise. I don't know if I've covered all the...
Yeah, you have. Thank you so much. Thank you, Dr. Madhur. I now come to Dr. Gajanan Mankikar. Ma'am, I'm sorry I had to keep you waiting for such a long time. But coming to you, I mean, as we mentioned earlier, the epidemic has now begun to affect young children. How does it? Why is the new COVID virus affecting new children? And it has been seen to affect pregnant ladies also. Should young couples postpone their pregnancies for a certain period of time? Uh, does this virus cause any harm to the fetus? And what extra care should a pregnant lady take if she gets infected by the virus? Why is the virus, as I mentioned earlier, why is the virus affecting young children? And how do infants cope with this infection? We've had cases where young infants, as young as 30 days or 1.5, 6 weeks, falling prey to the COVID infection. Is it allowed? I mean, is it possible for a mother, a COVID positive mother, to continue to breastfeed her child during that stage? Because in the first year, obviously, the child needs the breast milk. And what precautions should a mother take? Tomorrow, if vaccinations, at the moment, vaccinations have not been approved for children. Tomorrow, if vaccinations are approved for children, what is your opinion about the same? Over to you, Dr. Gajanan ma'am.
Thank you, Chaitanya ma'am. Jai Shankar. Yes, children are affected, and because of mutant virus and what is called as in WhatsApp language viral, the virus has become viral. That kind of a thing has happened. It has become rampant. Infection has become rampant, and in the event, the children also have got affected. Formerly, the children were not as affected as was in the previous year. But now, gradually, the number of patients are going up. It's just because the total picture has come up. The adults have affected, more adults have been affected. So that is why you see the children also being affected. And this is because of the mutant gene. And the things have been changing. But still, if you see the number of complications in a child are less, because about 4.5% children are develop complications, and they are not very severe as we see in the adults. We pediatricians are really lucky from that point of view. But then the effectivity is very high. It is what is called as RO factor, which Sangeeta said, that one patient can infect so many others. And the number of patients that are affected by one patient is called the RO factor. This RO factor has gone up. And the thing is, children are super spreaders. Children are super spreaders because people take them for granted. They are not suspected. And these children then spread infection. What happens is the children, social distancing is a problem for children. Children keep on playing with the neighbors, with relations who are staying quite near, and people, they just don't mind. Even if there's a lockdown or anything, they say, they keep on playing. They don't know what is social distancing. This because of this, the children have become super spreaders. The social distancing is a problem, and the care of the mask also. Masks are not used by children. The IIP has recommended masks for below 5 years. And to tell you very happily that my consulting, many children, even of 2 years, come with mask. I really appreciate the parents for the care they're taking for the children. Below 2 years also, after 2 years also, at 2 years also, people are taking masks. So this social distancing and these masks are very important. Now, what happens is these formats are not a problem nowadays. People say it's just the aerosols which cause. So lifts are not to be used. Children should not use the lifts at all, and of course adults also. But then aerosols can be prevented from the lifts. Now the one thing is for the grandparents. Children are so much associated with their grandparents. If a family is from a family person, one person is detected to be COVID positive, the whole family gets investigated, and we find that half of the family is negative, half of the family is positive. Immediately, what happens? They send a negative child to the grandparents who are staying coming from at the villages or some other part of the country, and the child goes there. But the child is negative initially, but then the child can become positive later on and pass on the infection to the grandparents elsewhere or the relations elsewhere. So these children should be contained should stay with the parents, and the family should plan out their quarantine properly. So if suppose the mother is negative and the child is positive, then the mother should should stay with the child with the mask, because child cannot stay alone in quarantine. The child has to be quarantined with the mother. The mother has to use the mask and quarantine the child. because otherwise the child is just super spreader. I told you, because child is very fond of, and people are very fond of the child. So this becomes very difficult for the family and otherwise. The quarantine period is as usual 14 days, and on the 17th day we can definitely say that a child cannot transmit the infection to others. So now what care should we take? We have to monitor the child. The children monitoring is a little different, because now in the temperature, SpO2, pulse, respiratory rate, activity, rash, and weight gain has to be seen. Temperature, if temperature goes up from more than 4 to 5 days, then that is important. We have to make a record. We always make prepare a plan and put it on our consulting prescription paper, and ask the parents to fill the form. The first thing is the temperature. If temperature is for more than 4 to 5 days, they should report to the doctor. Otherwise, they should come to the doctor every now and then. All these factors should be monitored. SpO2 if less than 94 has to be reported. Pulse also, suppose sleeping pulse is to be seen. If the child is sleeping, we see the pulse with the pulse oximeter. And if the pulse is rising, whatever pulse, because the pulses are different from day 1 to 18 years. So what happens? The pulse is very variable. So we have to find out your basic pulse for sleeping pulse in the child and see if that is rising. If that is rising, then you have to contact the doctor. Respiratory rate is very difficult. You need a little bit of training to do that respiratory rate, and the child should be quiet, calm. So that is a problem. Parents cannot really find the respiratory rate properly, but then they know that child is breathless. If they know that the child is breathless, they should contact the doctor. Activity, the child's activity is low. The child develops rash and weight gain. Nowadays, we have seen children getting weight gain because of this multisystemic inflammatory disease, which is syndrome, which is causing leak into the systems of the child because of inflammation, and the child retains a lot of food inside in the systems, and the child's weight gains. Within a short time, about 3-4 days, by 2-3 days, the child gains about 500 to even we have seen 1 kg of weight increase in older children. And we see that the children who are a little older are developing more complications than the younger one. At the moment, as Amembal ma'am said, that they have not seen a child below 4 months, but at the moment we have a child of 13 days old in my clinic, in my hospital, who is admitted for high-grade fever, and fortunately, the child had fever for 3 days, and then now the child is okay. We didn't have to give him anything. We just gave him paracetamol. We had to give him IV fluids because the child was not accepting any feeds. But now, by God's grace, the child is better. We didn't have to drug him at all. So, but then we have seen a child with 13 days with RT-PCR positive. The mother was negative, but now the mother also has been found to be positive. Probably they have got the infection from somebody else from the family, not from the mother. So this was the thing. This is a family infection from the family. So we have to be careful about all these parameters: temperature, SpO2, pulse, respiratory rate, and activity. And if the activity is low and the child is not accepting feed, that also has to be reported immediately. And what Sangeeta Pachi said, that she has seen that some patients behave like dengue. We have seen such a case because initially we found that one child had dengue fever symptom features clinically also, and investigation wise also. Low total count and low platelet count. But then, and the child had increase in weight also. Weight increase even in dengue because of this extravasation of fluid. In dengue also we get the same symptoms. But then that child had developed RT-PCR positive on the 3rd day of admission. Because before that we had done an RAT test which was negative. But then the child, and we thought it was just dengue. But then it turned out to be COVID only, and we had to treat the child as multisystemic inflammatory disease. So this was what Sangeeta Paji said. We found it in our practice. Now, what is we have to check the comorbidities also of the child. All children having diabetes and asthma have to be taken care of. Juvenile diabetes is not very uncommon. We find at least one new child in a month or so in big hospitals, in teaching institutes. We find at least 1 to 2 new patients every month, and the old patients keep on continuing, and there's a huge following of diabetics in general hospitals. So those people have to take care. Asthma people should start off their puffs immediately. If suppose there's a little bit of dyspnea also, they should start off their puffs. So that is one precaution we have to take. Now, Chaitanya ma'am said that about pregnancies. There is a IVF people infertility clinics were asked to lock down or want to stop their services during the last year's lockdown. So infertility services were supposed to be stopped for that period. But now they're seeing over a period of time that pregnancies are not remarkably affected, and people can go in for pregnancies, and complications are very low. Children are not affected as much. And even I checked up with Mankikar Hospital, which has got a big following. I checked up with KM Hospital also of Pune, and they also have not found as many problems of neonates developing COVID. But then the precaution that they take is that on the 5th day of discharge, they do an RT-PCR for the child, for the baby, to find out whether the child is infected or not. And if the child is infected, the child has to be taken care of properly. But the child cannot be handled by anyone and everyone in the house after the child goes home. So, and if they handle, they have to take care. They have to use the mask and sanitization. So that is the thing. Otherwise, even the neonate also may spread the infection. Mother has to feed the child. So if the mother is positive, the mother has to use a mask and take proper sanitary precautions and feed the child. The mother cannot be separate from the child. The child has to be with the mother, and the mother has to feed the child. So this is the dictum that the child should not be separate from the mother. So then you have asked what the young couples, can they go for pregnancy?
So I think you already answered that question.
But there's a funny thing. One of my assistants, she went in for she planned it so well. Now she's just delivered a child, and she's very happy. She has planned it properly. When she was at home, she had to stay at home. So then there is.
Thank you, Gajanan. Yeah, thank you.
About immunization.
Before
immunization.
Go ahead.
About immunization, children have always taken new vaccines quite well, and they may take this vaccine also well. Trials are going on, and the market will open out to the children also. But then, for the shortage of vaccine, they have been restricted, and only up to above 18 people are getting vaccinated. That's only because of the shortage of the vaccine. Otherwise, they would have vaccinated even the kids.
Yeah. Before my next question to Sangeeta, Dr. Gajanan ma'am, I would like you to continue. You yourself were a patient of COVID. You went through the trauma of suffering from COVID, and you were at home, and your entire family was also affected, I believe. How do you describe the experience of actually having had to go through this infection? What was the effect on you? Not just physically, of course, we know the physical effects, but what was the effect of COVID on your mental state? And because there is a tremendous stigma and a fear associated with the COVID infection. People are in a state of constant panic all the time. How did you manage to come out of that infection? How did you maintain your mental balance and your peace during the isolation period is what I would like to ask you. And what would you like to tell people about how to go about keeping your sanity intact during the COVID infection?
This is a very difficult question because I can tell you my personal experience. It was really difficult. It was very difficult because lots of WhatsApp reports come. All my close friends were affected. Some were affected very badly. Some were on the ventilator also. If not more, at least 3-4 of my close friends were there. And I had undergone a splenectomy, and I had lymphoma also sometime 5 years back. And my clinician who treated me for lymphoma, he said, you can't afford to get COVID. He had told me. So he said, you totally stop practice. It was very difficult for me to stop practice because I was in the hospital, so I had to continue. But I knew that one thing is there. If the morale of the patient is good, it works. So how to keep the morale up? So that was my problem. So that was the thing I thought of. And my morale was kept up by my daughter, my son-in-law, my wife, and all at home. They were continuously encouraging me, and they kept me in touch. They kept me in quarantine, and they said that we won't send you to the hospital, because those days everyone was rushing to the hospital. Dr. Amembal said, but then I didn't go to the hospital. I stayed back, and all these relations of my close ones, my daughter, my son-in-law, my wife, they encouraged me all throughout. They would come continuously in touch with me, and I used to do exercise continuously. Swamiji's exercise of Kapalbhati and Basrika helped me a lot. And because being engaged and having a proper program for the whole day, I was with that program. I didn't have time to think about negatively at all, because all these exercises kept me going, and all kinds of record keeping which was encouraging all the time, because I never my saturation did not fall to below 98 any time. So that helped me a lot. So and plus all the armamentarium which Swamiji has provided to us. So that like Anushtan, Devi Anushtan, then your Anushravas, which has reached everyone, every house, giving the feel of the touch of the Guru, Sanidhyam of the Guru. Anushravas has provided Sanidhyam of the Guru, and Sayujyam group is there with us as a representative, continuously with us to help us out to keep our morals up. So if the morale is up, even a bad patient can come up. If the patient is not very serious also, if his morale is down, he may deteriorate. So this you and I, we all clinicians know this. So morale is very important. So this morale kept up, and this association with people like you all, and what Mutt has provided, our Mutt site, which is so active. I've seen Deepa Tinekar Pachi, Sudha Tinekar Pachi, taking us to heights, new heights, and she creates a Mangal Vatavaran in the house. Every people are waiting for the Wednesdays to listen to her. And
Thank
of course, I
you
have a special mention to Shilpa Mudur Pachi's Kallol. Kallol is keeping the children very happy, and I've seen even I enjoy her sessions along with my 3-year-old granddaughter, and that is keeping me up. And I think we have been empowered to be equanimous and face all situations by Swamiji, by by the Anushtan and the Japa that he has given us. We have to be with him. That is all. And all the doctors that have told us just now, all those precautions we have to take. Swamiji also is very scientific. Always he's scientific minded. Whenever he speaks, he's always with the doctors and what science and what the scientific recommendations are. So we have to go through that. But this morale, which is important, which takes us away from this gloom of COVID. So this is what I think.
Thank you very much, Gajanan ma'am, for your personal experience, and thank you for all the praise that you have lavished on all of us. Thank you. So coming to the last question of the day, before I go to questions from audience, the last question is to Dr. Sangeeta Nadkarni. Is about the vaccines. We've had a big vaccine controversy, of course, on television also. We have the Covishield and an ingenious Covaxin. And of course, we have the vaccine that is available in the US, the Moderna and the Pfizer vaccines and the Johnson & Johnson vaccines. So we have an array of vaccines which is confusing the population about which vaccine, whether there is a choice, which vaccine is more effective. What are the, if you could, there is a shortage of time. We've reached almost 1.5 hours. So if you could, put it in a very short an answer, talk about the various vaccines and give us some information about the intervals between the 2 doses and how long the immunity would last. And also I would like to you to talk about is, suppose there have been cases where a person after taking the first vaccine dose has fallen prey to COVID. So after the COVID infection, what interval must he keep before he takes the second dose? And if somebody has already suffered from COVID, do they need to take the vaccine? Over to you, Dr. Sangeeta.
Thank you, Chaitanya ma'am. We have at present in India 2 vaccines. That is, as all of you know, it's the Covishield and Covaxin. Covishield is developed by Oxford AstraZeneca and produced by Serum Institute of India. Covaxin is produced by Bharat Biotech in association with NIV and ICMR. Now, the efficacy of both Covishield and Covaxin is 72% and 78%. But recent trials on Covishield, they have said that it has improved to 90%. Now, the intervals, the first dose and earlier the second dose of Covishield was to be taken after 28 days. But now, again, data and research has said that if taken 6 to 8 weeks after the first dose, the immunity is much better and the response of the body is much better. In the Covaxin case, it is 28 to 36 days. after the first dose. Now, if a person gets all vaccines actually don't say that you will not get COVID virus. You can get infected with the COVID virus post-vaccination, but it will be a very mild form. There won't be hospitalization, there won't be any ICU admission, or there won't be any serious complication. Now, if a person has taken the first dose and then he gets COVID infection, he has to wait, or if the person has got just COVID infection, it is better to take the vaccine about 6 to 8 weeks after the COVID, after you have recovered from the COVID infection, because they say that you have the COVID antibodies, natural antibodies to the COVID infection to protect you for that period. And then if you wait for 6 to 8 weeks and then start the vaccination schedule, that's much better. Now, suppose a person has taken the first dose and gets COVID after that. Again, the same thing. After he recovers from COVID, he could probably wait for 5 to 6 weeks and then take the second dose. Now, the immunity lasts. They haven't yet. The research is still going on, but of late the data has been saying that the immunity lasts for 6 months. But nothing very confirmatory. I think in the next few months, we'll come to know whether we need to take a booster dose after 6 months or 1 year or whatever it is. The other vaccine which has come now is the Sputnik V, which has just arrived in India from Russia a week ago. Now, this also has 2 doses, I think 28 days apart. The Moderna and the
Pfizer vaccine.
Pfizer vaccine from the US, they think that is 93% effective, and the technique is the mRNA. It is the mRNA of the coronavirus which is injected into the body. While for Covishield and Covaxin, the principle is slightly different. The Covishield is using an adenovirus which causes cold in chimpanzee, and this goes into the body and initiates the spike protein of the coronavirus, and then the B and T cells are instructed to form antibodies to this virus. The Covaxin is a dead or inactivated coronavirus which has been injected into the body, and this initiates the antibodies to the spike protein directly.
Okay. Thank you very much, Dr. Sangeeta. We will now go to the questions from the audience directly. I have a question. I mean, please keep the answers very short because we have exceeded our time. There was a question whether if there are asymptomatic patients in the house, do they still have to test their SpO2s regularly till the end of the period, Dr. Vivek? And is it necessary? Okay, yeah, go ahead.
Yes. Yes, we advise patients to keep a diary and to let us know 3 times a day, morning, afternoon, and night, taking oxygen saturations. Especially older people have something called hypoxia, which cannot sometimes be ascertained unless you have the pulse oximeter readings. So it is good practice to take the readings 3 times a day and inform your healthcare provider, family doctor or physician once a day or twice, once in 2 days.
Okay. Okay. Thank you.
It also gives the pulse reading.
Okay. Okay. Dr. Madhur, a question for you. Would it be necessary to wear masks at home even if there are no cases? Do you recommend that?
Well, for people who have maid servants who are coming from outside, then ideally I would suggest that it is far better for them to wear a mask during that period when they're there. But if they're only with their regular people in the household, then that may not be necessary.
Dr. Madhur, you also mentioned that there's a lot of steroid use in the hospitals in serious cases. Now we have patients with diabetes, and there are certain side effects because of the steroids, where these patients could go into ketoacidosis or septic shocks, cardiac arrest, etc. So what would you say on this? I mean, is the use of steroids justified?
The use of steroids is justified. 1, 2 is it is very cautiously used in such patients who are known diabetics because they're very closely monitored. So it would be unlikely that they would get steroid-induced ketoacidosis as a result of that. Septic shock by itself, yes, there is a role for antibiotics to be used because there is secondary bacterial infection in a lot of these patients. But they're very careful about the use of steroids in anyone who has got comorbidities or is a known diabetic. So it's unlikely that that steroid itself is necessarily going to, because it's for a short course anyway. It's 5 to 10 days that they would be asking them as per the guidelines to be using it.
Okay, thank you. There's another question for you, Dr. Sangeeta. There is a test that patients frequently do. They want to know whether they have antibodies for COVID, and COVID patients frequently check their blood for COVID antibodies. Is this necessary? Is it required? Do patients who have not suffered from COVID also need to test their blood for COVID antibodies? There is a lot of debate going on about this COVID antibody test. What do you have to say on this?
No, actually, COVID antibody test is really not necessary. But in case a patient wants to check his immune system and how immunity works, many people get it done, the COVID antibodies. And another case is like if the patient was RT-PCR and clinically suspected to be COVID. It's worthwhile doing COVID antibodies later on. So at least he knows that he had suffered from COVID. But the spike protein antibodies, which have come now, post-vaccination, it's worthwhile doing that after 4 weeks to know your response to the vaccination.
Okay, thank you. Dr. Gajanan, just a short question to you. There are a lot of questions about Ayurvedic kadas and Ayurvedic medicines that are being used, kashayas that are being used by a whole lot of our Indian population. Do you think they play any role in the prognosis of the disease or in the prevention of the disease?
I don't think, because there's nothing proved in these kind of medicines. I don't think they really help. But the only thing I always recommend people to have a lot of fluids, hot fluids, and so that the child perspires well and the fever comes down. They don't need a lot of antibiotics. That's the only thing I prefer.
Thank you, Dr. Gajanan. A last question to Dr. Madhur. Do you think the government has, there's a lot of criticism about the government handling the COVID spike. Was it possible for the government to have been better prepared, or was it, or is the government doing enough to tackle the shortages in oxygen and the other drugs? Dr. Madhur?
Yeah, I think the government could have done a lot more in preparing. So I think it was more a reactive situation than being proactive. So we found that also in the first wave, where all these centers were then set up for COVID centers or jumbo centers like we have had in Pune. And when the numbers started going down, they just dismantled it, I think in a rather hurry, and asked all the doctors and the nurses and paramedical staff to go away. And then when we were hit by the second wave, they had to restart the entire thing, which took quite some time for them to do. So the pressure again fell on a lot of the private hospitals to try and accommodate all these patients. So there is a lot that could have been done. I mentioned at one stage about testing, tracing, and isolating could have been done during the first phase. And also now, in terms of the medicine distribution, yes, there is, if the supply is not there, then you can't blame the government, but there obviously needs to be some control, and which they have now started doing and getting it only distributed through the district collector based on our requirements. Obviously, all of those are not fulfilled. So right now also I'm getting messages about patients not receiving their remdesivir for today. And unfortunately, they end up blaming the hospital for that, despite the fact we tell them that we don't have the drug, so we can't give what we don't have. And there's nobody within the government authorities that allays those fears by saying that it's not the hospital's fault. So I think there's a lot that can be done in terms of the communication in the way they handle things, and making people aware of the fact that there's a distribution system, be it for oxygen, be it for remdesivir, be it for any of the other drugs, which the hospital per se is not going to be able to control unless we get the supplies. We can't provide it to any of our patients.
Thank you, Dr. Madhur. I'm sure the government is reading up, reach out to the people and to the hospitals. I mean, to compare, going back, if I look back, when the first lockdown was imposed, the state of affairs of our infrastructure was really bad. We did not even have PPEs. We did not have any kind of testing facilities. It was only the Serum Institute, the Indian Institute of Virology in Pune that was only checking for the virus. And today we have laboratories all across the country. We have become self-sufficient in PPEs. And the government was, of course, seized of the matter regarding oxygen. I remember reading a report where the central government dispersed funds to all state governments, requesting them to set up oxygen plants. However, some of the governments did not comply, and the burden had to be borne by the common man. Of course, this is a natural calamity. It is like a flood situation, or it is like a disaster, a natural disaster, and there is as much as we can do. And we also have, to a certain extent, we are ourselves to blame for not taking precautionary measures. We took it very easily. I mean, became very lax in the latter half of last year, and in the early part of the year we started going back to weddings and parties and not wearing masks and throwing all caution to the winds, and probably it has come back. But then I'm sure it has played a major role in boosting up our infrastructure, I must say, because the infrastructure in India has greatly improved now, both in the private and the public sector. Governments are seized of the matter. We did not have enough ventilators at that stage in last year. We now have enough ventilators in almost all the hospitals, and the facilities, medical facilities, have also improved in the rural areas to a great extent because of the COVID pandemic. However, I'll have to sum up for want of time. It was a very interesting webinar with a treasure of information given by all of you, all the panelists. I would like to thank each one of you individually for agreeing to participate so readily in this seminar and for sparing your time, taking time out of your busy practice to participate in this seminar. I would also like to place on record our deep gratitude to Parama Pujya Srimad Sadhya Shankarasham Swamiji for having given us an opportunity to organize this seminar and reach out to the Samaj. My heartfelt thanks to the technical support team of Kumble Sharmila Pachi and Chandavarkar Aditya Ma'am, and for supporting this webinar, and the SCM website team of Nail Shantish Ma'am and Rao Linata Pachi for the publicity given to this seminar. And of course, thanks to the entire Sayujyam team, and of course to Hebrekar Kutimam, who leads the Shibir activities team. And thanks to all of you for participating in this webinar. And thank you to, I hope, for want of time, it is very difficult to encapsulate the entire plethora of information about COVID into one single webinar. But we have made an attempt. Thank you very much. And to conclude, I will be chanting the Sabha Samapti Prarthana. Om Nandantu Sadaka Sarve Vinashyantu Vidushakaha Avastha Shambhavi Mestu Prasannostu Guru Sada Sarve Bhavantu Sukhinaha Sarve Santu Niramayaha Sarve Bhadrani Pashyantu Ma Kashchid Dukkham Apnuyat. Om Shanti Shanti Shanti. Om Namah Parvati Pataye Har Har Mahadev.